Internal fixation of metacarpal and phalangeal fractures is technically demanding. With conservative management, adjacent joints as well as dynamic structures are immobilized. Secondary displacement is not uncommon. The Penig Mini fixator combines the advantages of secure external stabilization with an atraumatic operative technique. In the sterilization box, the fixator bodies are placed on the upper right-hand side. Below are the standard clamps. Top left are the L clamps, and in the middle of the box, two types of threaded wires. The specially designed threaded wires with an outer diameter of 1.6 mm are used for phalangeal bones and 2 mm for metacarpal and metatarsal bones. The reduction forceps are placed bottom left. The mini fixator includes a double ball joint which connects two threaded bars. Fracture reduction in all planes is thus possible. The double ball joint is locked by turning a single screw in a clockwise direction. The fixator clamp is placed on the threaded bar. Securing of the clamp on the bar is achieved by tightening the bottom screw of the clamp. A nut placed between the double ball joint and clamp can be used for distraction. The same nut placed on the outside of the clamp is used for compression. For short phalangeal bones, a left and right L clamp is available. With these clamps, bridging a joint is not necessary unless dictated by the fracture. The fixator clamp is used as a template to insert the threaded wires into the bone. The center cam in both the standard and L clamp locks the threaded wires once they have been inserted through the appropriate openings in the clamp. While the threaded wires are being inserted, the dot on the cam must face the dot on the surface of the clamp. When positioned horizontally, the threaded wires are parallel. In the vertical position, the threaded wires converge. The technique allows stabilization of small periarticular fragments and may thereby avoid bridging of the joint. The distance between the tips of the threaded wires can be varied by advancing and retracting them. On a sawbone, stabilization of a simulated distal dia and metaphyseal fracture of the fifth metacarpal bone is carried out. The first 2 mm threaded wire is inserted from the ulnar side. The fixator clamp is being pushed over the wire. After trimming the first wire, a second is inserted in the hole above the first. The wires converge in the head of the fifth metacarpal bone. For the application, a short mini fixator body is chosen, and the shorter bar is inserted into the clamp. The double ball joint is slightly tightened to allow application of the fixator parallel to the bone axis. The second clamp is now inserted, and the 2 mm threaded wires are introduced horizontally, parallel to one another. When inserting the threaded wire, the tip should not protrude from the opposite cortex. After insertion of the first wire, it must be trimmed, so that it will not obstruct the insertion of the second wire. Prior to reduction, the double ball joint and the locking screw of one clamp are loosened. The cam in both clamps is tightened, however, to secure the threaded wires. The reduction forceps are mounted on the clamps to provide leverage for reduction of the fracture. At the same time, the surgeon's hands are distanced from the radiation beam. After reduction has been achieved, all loose screws are tightened, starting with the double ball joint. It is recommended that this procedure is repeated once. The clinical application of the mini-fixator is illustrated in a diaphyseal fracture of the fifth metacarpal. Clinical reduction prior to application of the fixator is recommended. A tourniquet is not necessary. A hand table is used and a rolled-up towel facilitates positioning of the hand. From the ulnar side, the first 2 mm threaded wire is inserted percutaneously in the distal metaphysis of the metacarpal bone. With difficult soft tissue conditions or in other metacarpal bones, a small incision may be necessary to expose the bone. Insertion of the threaded wire should be checked radiographically. The tip of the wire should engage the opposite cortex but not protrude beyond it. The fixator clamp is pushed over the wire end, which is now trimmed. The distance clamp to skin should be 5 to 10 mm. Since the distal fragment in this case is long enough, the second wire is inserted parallel to the first. In short distal or proximal fragments, convergent insertion of the wires is recommended. Correct positioning of the wire is again checked radiographically. A mini-fixator body of a suitable length is chosen, and here a short mini-fixator will be used. The threaded bar is inserted into the clamp and tightened in a central position. The cam in the clamp can also be tightened to secure the threaded wires. The double ball joint is locked clockwise half a turn to allow alignment of the fixator body with the long axis on the bone. The second clamp is placed on the bar and the 2 proximal threaded wires are inserted. Correct positioning is verified radiographically. Prior to reduction, the double ball joint and the fixator clamp locking screw are loosened. Clinical reduction may now be carried out. This often results in anatomical repositioning of the fracture. The reduction forceps are mounted on the fixator clamps and used to achieve reduction of the fracture. At the same time, the surgeon's hands are distanced from the radiation area. After reduction, all fixator screws are locked and checked once again later. X-rays show anatomical reduction. In the fractures of the metacarpal bones and fingers, rotational deformity must not occur, and clinical examination to exclude this is necessary. All adjacent joints should move freely. A dry dressing is used to cover the fixator, and no further dressing or splinting is required. Physiotherapy should start on day 1 following surgery. The patient is not allowed to lift heavy items or to use the hand for strenuous tasks. Skin care around the threaded wires is recommended twice a week. The fixator screws should be checked and retightened if necessary during the post-operative period. The fixator remains in situ for approximately 5 weeks. X-rays are taken after 1 week, 3 weeks, and at the end of treatment. Removal of the threaded wires is carried out with a special threaded wire extractor in the outpatient department. Local anesthesia is not usually necessary.